Welcome. In this session, we'll be discussing about ocular ischemic syndrome. Ocular ischemic syndrome or OIS occurs due to chronic ocular hypoperfusion from ipsilateral severe carotid artery obstruction. In contrast to retinal arterial occlusions, which occur due to obstruction in the retinal arterial system with an acute onset, OIS occurs due to obstruction in the carotid artery and usually have an insidious onset. Also, in retinal arterial occlusion, only the retinal circulation is affected, but in OIS, both the retinal and the choroidal circulations are affected. On the other hand, clinical examination of an eye with OIS shows retinal hemorrhages, and so OIS needs to be clinically distinguished from other conditions which commonly cause retinal hemorrhages, such as central retinal vein occlusion and diabetic retinopathy. OIS is a rare entity with an annual incidence of 7.5 cases per million individuals with a mean age of presentation of 65 years. OIS occurs more frequently in males as compared to females in a 2:1 ratio, and in 20% of cases, OIS occurs bilaterally. OIS is associated with 90% or more stenosis of the ipsilateral carotid artery, either the common carotid or the internal carotid artery. So these two figures show the common carotid artery and the internal carotid artery obstruction, in which can cause OIS. A 90% obstruction in the carotid artery leads to a 50% reduction in the perfusion pressure in the central retinal artery, and 50% of all OIS patients actually have 100% obstruction in the ipsilateral carotid artery. On the other hand, only 5% of individuals with hemodynamically significant carotid artery stenosis develop ocular ischemic syndrome, and this depends on the extent of collateral development between the external carotid arterial system and the internal carotid arterial system. Uncommonly, a portion of the globe may be supplied by branches of the external carotid artery, and in this situation, external carotid obstruction can lead to OIS. And although uncommon, obstruction of the ophthalmic or the central retinal artery, which are branches of the internal carotid artery, can lead to OIS. The most common cause of obstruction leading to OIS is atherosclerosis, usually near arterial bifurcations, and other causes of obstruction which can lead to OIS include carotid dissection, Takayasu arteritis, Moyamoya disease, radiation injury, Eisenmenger syndrome, and giant cell arteritis. So risk factors and associations of OIS are the diseases associated with atherosclerosis, such as systemic arterial hypertension, diabetes mellitus, hyperlipidemia, peripheral vascular disease, ischemic heart disease, and previous cerebrovascular events. And the figures given in the parenthesis are the proportion of OIS patients who have these comorbidities. 5-year mortality rate among OIS patients is 40%, with the most common cause being cardiovascular event and the second most common cause being a cerebrovascular event. And one study found that 70% of OIS patients had OIS as the only manifestation of carotid occlusive disease. The typical symptoms of OIS are visual loss, prolonged recovery of vision following exposure to bright light, and pain in and around the eye. Visual loss is reported by more than 90% of patients with OIS at presentation, and among them, the majority complain of gradual loss of vision over weeks, and a few may complain of sudden loss of vision when a central retinal artery occlusion occurs in an eye with OIS. We will be discussing how central retinal artery may occur in an eye with OIS later in this session. 10 to 15% of OIS patients may have a history of amaurosis fugax or transient visual obscurations, and these occur due to embolism to the central retinal artery from the site of obstruction in the carotid artery. Prolonged recovery of vision following exposure to bright light is a typical symptom of OIS, and 40% of OIS may complain of a dull ache in the eye and around the orbit, which is typically worse in the upright position and is said to occur due to ischemia of the globe or dura. And this pain of OIS is also called ocular angina. Neovascular glaucoma with raised intraocular pressure, which is a complication of ocular ischemic syndrome, can also cause ocular pain. But as we will be discussing further, only 50% of OIS eyes with anterior segment neovascularization have elevated intraocular pressure. The presenting visual acuity in eyes with OIS has a bimodal distribution, with 43% having a visual acuity better than 20/50 and 37% having a visual acuity of counting fingers or worse. But after 1 year of diagnosis of OIS, the visual acuity worsens, with 58% having a visual acuity of counting fingers or worse, and the visual prognosis is poor without surgical intervention for the carotid obstruction. Prominent scalp collaterals connecting external carotid arteries of either side, as seen here in this clinical photograph, can occur in patients with 100% or total obstruction of common carotid artery of one side. This patient had common carotid obstruction in the left side, and the scalp collateral should not be confused with enlarged tender temporal arteries of giant cell arteritis, because this misdiagnosis can lead to an inadvertent temporal artery biopsy, which leads to interruption of blood supply to the brain and eye on the side of the common carotid artery obstruction. Anterior segment examination of OIS eyes can show anterior segment neovascularization, anterior chamber inflammation, and cataract. Anterior segment neovascularization is found in 2/3 of OIS eyes at presentation, but almost half of these eyes with NVI have IOP in the normal range, even if there is synachial closure of the anterior chamber angle from angle neovascularization, and this is very important to remember. And this is because chronic hypoperfusion leads to decreased ciliary body perfusion, which results in decreased aqueous humor production. Anterior segment neovascularization in OIS eyes is a poor visual prognostic criteria, as visual acuity decreases to 20/200 or worse in 90% of OIS eyes within 1 year following development of NVI. Reperfusion following carotid artery surgery can lead to severe elevation of intraocular pressure due to restoration of ciliary body perfusion, which leads to normalization of aqueous humor production. Mild to moderate anterior chamber inflammation can be found in eyes with OIS, and flare is more common than cellular reaction in OIS eyes, and development of cataract is common in eyes with advanced OIS. Characteristic posterior segment findings in eyes with OIS include retinal vascular changes, retinal hemorrhages, and spontaneous or inducible arterial pulsation. OIS eyes typically show narrowing of all arteries and dilatation of all veins, as seen here in these two clinical photographs. The dilated veins may be beaded, but not as severely as that found in severe NPDR. And in contrast to CRVO, the dilated veins are not tortuous, and this is very important to remember. So in these two clinical photographs, we find dilatation of all veins without any tortuosity and narrowing of all arteries. Retinal hemorrhages are found in 80% of eyes with OIS and is most commonly dot blot in appearance and occurs in the mid-periphery of the retina, as seen here in these two color photographs, and this is very important to remember. In comparison to retinal hemorrhages found in CRVO, hemorrhages in OIS are less numerous and are not confluent, as seen here in this clinical photograph. Spontaneous arterial pulsation occurs in 4% of eyes with OIS, and the pulsation of arteries appear to extend along the arteries about the disc diameter from the surface of the disc, and this is in contrast to spontaneous venous pulsation, a normal finding in some eyes which is localized to the base of the veins at the surface of the disc. And in OIS eyes which do not show spontaneous retinal arterial pulsation, application of only a small amount of pressure on the globe can elicit arterial pulsation, and spontaneous or inducible arterial pulsation is a very characteristic finding of eyes with OIS. Microaneurysms are also found in eyes with OIS, and like retinal hemorrhages found in OIS eyes, microaneurysms in eyes with OIS are usually peripheral to the posterior pole. Less commonly, cotton wool spots may be found and are usually peripapillary in location, but hard exudates do not occur in eyes with OIS. Neovascularization of the disc and neovascularization of the retina can occur in eyes with OIS, but are much less common than neovascularization of iris. And a central retinal artery occlusion with a cherry red spot can be found in some eyes with ocular ischemic syndrome, as seen here in this clinical photograph. CRAO is said to occur in eyes with OIS either due to elevated intraocular pressure from anterior segment neovascularization exceeding the low perfusion pressure in the central retinal artery or due to embolism from the site of obstruction in the carotid artery. On fluorescein angiography, the majority of eyes with OIS show delayed arteriovenous transit time as seen here in these two angiograms with a leading edge of the dye as can be seen in this angiogram, and 60% of eyes with OIS show delayed and patchy choroidal filling, and this is the most specific fluorescent angiographic sign of OIS as seen here in this angiogram, and this is very important to remember. This is very specific for OIS because in retinal vascular diseases, both retinal arterial occlusions and retinal venous occlusions, retinal filling is delayed as in OIS, but choroidal filling remains normal. Other signs on fluorescent angiography in eyes with OIS include blocked fluorescence from retinal hemorrhages, hyperfluorescence from microaneurysms, retinal capillary non-perfusion, and late staining of retinal vessels as seen here in this fluorescent angiogram, which also shows hyperfluorescence from microaneurysms and blocked fluorescence from retinal hemorrhages. This fluorescent angiogram also shows late staining of retinal vessels in an eye with OIS, and staining in eyes with OIS occurs in both large and small retinal vessels and mainly arteries. And this is in contrast to CRAO, in which vessel staining is not found on fluorescent angiography, and CRVO, in which staining of veins are found on fluorescent angiography. Macular leakage on fluorescent angiography can be found in some eyes with OIS, and this is usually associated with leakage from the disc also. But macular leakage and disc leakage on FA in eyes with OIS is not associated with swelling of disc and prominent cystic changes in the fovea clinically. OCT in eyes with OIS may show paracentral acute middle maculopathy, which we have discussed in detail in the previous session, and which may be the only ocular feature, either clinical or diagnostic, of an eye with OIS. Decreased choroidal thickness is also found on OCT in eyes with OIS. On OCTA, eyes with OIS show reduced flow to the optic nerve and the retinal circulation, and ERG shows reduction in amplitude or absence of both the A waves and the B waves, as both the retinal and the choroidal circulations are affected in eyes with OIS. Reduction in oscillatory potential along the ascending limb of the B wave on ERG may also be found in eyes with OIS. Visual evoked response shows delayed recovery of response on photostress testing in eyes with OIS, and color Doppler imaging of the retrobulbar blood vessels may show reduction in peak systolic blood flow velocity in the central retinal artery and reversal of blood flow in the ophthalmic arteries. Carotid angiography is a very important diagnostic test in patients with suspected OIS, and CT angiography shows 90% or more stenosis in either the ipsilateral internal carotid artery or the ipsilateral common carotid artery, and although CT angiography can delineate the plaque, it cannot assess other plaque characteristics which magnetic resonance angiography can perform. Magnetic resonance angiography, as seen here in this photograph showing obstruction of the left common carotid artery, in addition to delineating the plaque and the stenosis, can define plaque characteristics as shown here in this photograph, and these plaque characteristics can potentially predict the risk of future thrombosis and embolism. As we have mentioned in earlier sessions, carotid Doppler imaging is not as sensitive in detecting stenosis because it cannot image the intrathoracic and intracranial portion of the carotid arteries. Other tests for OIS which are not currently done routinely include ophthalmodynamometry and oculoplethysmography. Since ocular ischemic syndrome is characterized by retinal hemorrhages, the differential diagnosis of ocular ischemic syndrome includes central retinal vein occlusion and diabetic retinopathy. Hemorrhages and microaneurysms in OIS are mostly located in the mid-peripheral retina, but in the posterior pole in CRVO and DR. The veins in ocular ischemic syndrome are dilated and beaded but not tortuous, like the dilated and tortuous veins of CRVO. In DR, the veins can be dilated, beaded, and also tortuous. Hard exudates are not found in OIS but may be found in CRVO and is commonly found in DR. Optic disc appears normal in OIS and in most cases of diabetic retinopathy but appears swollen in CRVO. Spontaneous or inducible retinal arterial pulsation is present in eyes with OIS but is absent in eyes with CRVO or DR. Arteriovenous transit time is delayed on fluorescent angiography both in eyes with OIS and in eyes with CRVO but is usually normal in eyes with diabetic retinopathy. Choroidal filling on fluorescent angiography is delayed and patchy in eyes with OIS but is normal in eyes with CRVO or diabetic retinopathy. Vessel staining is arterial in OIS, venous in CRVO but is usually absent in eyes with diabetic retinopathy. Carotid surgery is the definitive treatment for ocular ischemic syndrome, and total or 100% occlusion of a carotid artery requires extracranial to intracranial bypass surgery by anastomosing the superficial temporal artery to the middle cerebral artery. Following this procedure, vision improves in only 20% of patients, and that too transiently, but usually deteriorates within 1 year of the procedure. Carotid end arterectomy does not work in total or 100% occlusion of the carotid artery, and this is said to be because of distal propagation of the plaque within the carotid artery after 100% obstruction of the vessel. Carotid end arterectomy is the treatment of choice for less than total occlusion of a carotid artery and is indicated for 70 to 99% stenosis of the carotid artery. In carotid end arterectomy, an incision is made in the affected portion of the carotid artery, the plaque within the carotid artery removed, and the carotid artery then sutured. Overall, visual acuity stabilizes or improves in 1/4 of patients undergoing carotid end arterectomy, and the visual prognosis is better if carotid end arterectomy is performed before iris neovascularization develops. And as we have mentioned earlier, in eyes with synechial angle closure from neovascularization of the angle, severe elevation of intraocular pressure can occur following carotid end arterectomy due to restoration of ciliary body perfusion, leading to increased aqueous humor production. But there is a 2% risk of ischemic stroke occurring immediately following carotid end arterectomy, and this is important to remember. The North American symptomatic carotid end arterectomy trial found that carotid end arterectomy is highly beneficial in patients with a recent history of amaurosis fugax, transient hemispheric attacks, and non-disabling strokes only when the stenosis is between 70% to 99%. This is because only with this severity of obstruction in the carotid artery, the 2-year reduction in the risk of ischemic stroke with carotid end arterectomy compares favorably with the increased risk of ischemic stroke immediately following carotid end arterectomy as compared with patients treated with antiplatelets only. And if carotid end arterectomy is indicated in a patient, American Heart Association recommends that the procedure be performed within 14 days of the event, either a transient visual loss or a transient ischemic attack. Stenting of the carotid artery is an alternative to carotid end arterectomy, but it has not been extensively studied in patients with ocular ischemic syndrome. Since atherosclerosis is a major risk factor of ocular ischemic syndrome, medical therapy includes control of hypertension, hyperlipidemia, diabetes mellitus, and smoking. And since the major cause of mortality in patients with OIS is cardiovascular events, cardiac evaluation by a cardiologist is recommended in patients with OIS. Panretinal photocoagulation is indicated for iris and posterior segment neovascularization in eyes with OIS, but regression of neovascularization occurs much less frequently in eyes with OIS as compared to eyes with ocular neovascularization from retinal vascular diseases. Intravitreal bevacizumab or triamcinolone may be administered in OIS eyes with macular edema, but it is important to remember that intravitreal injection may increase the intraocular pressure and further compromise the choroidal and retinal circulations, which have reduced perfusion pressure in ocular ischemic syndrome, and this is very important to remember. and so immediately following the intravitreal injection, if signs indicating further compromise of the retinal or choroidal circulation is detected, such as narrowed retinal arteries, optic disc pallor, or lightening of the fundus color, immediate anterior chamber paracentesis should be performed to preserve vision in that eye. To recap the salient points, ocular ischemic syndrome or OIS occurs due to chronic severe ocular hypoperfusion due to 90% or more obstruction in the ipsilateral carotid arteries, either the common carotid or the internal carotid artery. Atherosclerosis is the most common risk factor, with 5-year mortality rate of 40% among patients with OIS following diagnosis of OIS. Patient with OIS usually presents with gradually worsening visual acuity, pain in and around the eye, and prolongation of visual recovery following exposure to bright light. Some patients may give prior history of transient visual obscurations also. On examination, anterior segment may show iris neovascularization and synechial angle closure with or without elevated intraocular pressure, mild to moderate anterior chamber inflammation, and cataract formation in eyes with advanced OIS. Posterior segment examination shows narrowed retinal arteries, dilated but not tortuous retinal veins, dot blot hemorrhages in the mid-peripheral retina, and arterial pulsation, either spontaneous or inducible with mild pressure on the globe. Neovascularization of the disc and or the retina and cherry red spot due to CRAO may be found in eyes with OIS. Fluorescent angiography in eyes with OIS show delayed arterial filling, prolonged arteriovenous transit time, delayed and patchy choroidal filling, which distinguishes OIS from retinal vascular occlusions, and late staining of the arteries. ERG shows reduced amplitude or absence of both the A and B waves. Carotid angiography, either with CT or MRI, shows the site and degree of obstruction in the carotid artery. Differential diagnosis of OIS includes CRVO and diabetic retinopathy. Superficial temporal artery to middle cerebral artery anastomosis may be attempted in complete or 100% obstruction of the carotid artery, but long-term results are poor. Carotid end arterectomy is indicated for 70 to 99% carotid artery obstruction, following which visual acuity is maintained or improved in 25% of patients, but results are better if carotid endarterectomy is performed before iris neovascularization develops. Following carotid end arterectomy, there can be acute elevation of intraocular pressure in OIS eyes with synechial angle closure from angle neovascularization. Carotid endarterectomy itself can induce ischemic stroke in 2% of patients undergoing the procedure in the immediate post-operative period. Carotid end arterectomy does not work in 100% obstruction in the carotid artery. Medical therapy includes cessation of smoking and control of hyperlipidemia, hypertension, and diabetes. Panretinal photocoagulation is indicated for neovascularization, but the rate of response is worse than that in retinal vascular diseases such as diabetic retinopathy and retinal vein occlusion. Thank you for listening.